Wait, you can go ahead, Vernon.
Good afternoon, colleagues, and welcome to this month's patient blood management session. Wonderful to see so many people in the room already. I'm sure a few more will join us. We have a great speaker this afternoon with an incredibly important topic. So I really look forward to that, and I will introduce Dr. Wessels in a moment. But first, I just wanted to let you all know, remind you that this Gastro Echo sessions, that these are hosted by the Gastro Foundation in association with Project Echo at the University of New Mexico. And they are held weekly on a Wednesday, and every week there are different sessions, typically gastroenterology related things like endoscopy, liver disease, etc. But once every 6 to 8 weeks, we have a patient blood management session for which we're very grateful. And we thank the Gastro Foundation for supporting us in doing this. The chat will be open for questions, so please make use of the opportunity. And without further ado, I know you all would like to get home as well. I would like to introduce Dr. Petro-Lize Wessels, who I am sure many of you know already. Petro-Lize has been a person with a great passion for patient blood management and has been working for the South African National Blood Service as the medical officer responsible for patient blood management for a number of years, and she and her team has been doing fantastic work. So Petro-Lize, I've had the privilege of listening to you speak on the different elements of ethics related to blood and blood transfusion, and it has always left me with a lot of food for thought and actionable items. And I'm sure, and I hope that many of you today will go home with the same. And I think you will, as you listen to Petro-Lize, you'll think to yourself, oh, I wish my junior doctors were here. So I hope some of you have some of them in the room. If not, WhatsApp them to join in. They're very welcome. But Petro-Lize, thank you so much for gracing us with your presence, for offering to give this talk once again, and for sharing your experience and knowledge, and also the areas that you have found where we as doctors on the floor seeing patients can do better. Over to you.
Thank you very much. Thank you for the invite. Thank you to Gastro Echo for always allowing time for these important topics. And let me start sharing. If all goes well, you should be seeing it in presentation mode on your side.
Yes, we can.
Oh, fantastic. First time lucky. You see, getting better with age. So, like Vernon said, this is a talk that I often give. I'm just going to switch off my video. I don't want the audio to lag a bit, and I'm not in a very good spot for reception. This is a topic that I often present on, and the reason why I'm passionate about this is because nobody told me this. I was in clinical medicine for 18 years before I stumbled into the world of transfusion, and only when I joined SANBIS did I learn about many of these considerations. And it's very important for me to share this with my colleagues out there. So let's get going. So I'm a firm believer in informed choice. So there's the summary of the talk, as always, and then you can decide whether you want to stay or whether you want to go home early. But I need to give you more information, and otherwise you can't make a decision. Eh? So the little diaper-wearing devil with the very sharp pitchfork is the law, and our fairy godmother is patient blood management. So there you have it, enough information to make an informed choice. So if a blood banker is sitting here and showing you these little pictures in an ethic talk, things has changed over the past years. And one of the things that has changed is because we as doctors now have to deal with the right choices of conduct considering all the circumstances. I cannot consider what I was told when I was a 6-year medical student way back in 92. Things have changed and my considerations must change as well. Transfusion ethics is no longer an isolated thing. It's not only about the transfusion of blood and blood products. We as healthcare workers have a duty much bigger than the patient sitting in front of us. And everything we do, our thinking, our actions, it's not just about preventing inappropriate transfusions. It's also about what's best for the broader public. And how do we achieve the full health potential of each and every patient that we come in contact with? That's a concept called health equity. PBM principles is nothing new. It's been widely published. It's been published for as far back as 40 years ago, and we can't say we did not know anymore. It should form part of basic patient evaluation, interaction, and treatment plans. So a lot of the headaches are me and my colleagues, the donation, the processing, the testing, the governance of a blood service. Let's talk about what is of importance to you as the practicing doctor or nurse in the South African setting. Let's start with ethics. That's always easier to digest this time of the day. And Koski said ethics is the branch of knowledge that deals with moral principles. And no longer do we as doctors only have to decide what is the best treatment. We also have an ethical obligation to benefit the patient, avoid or minimize harm, and respect the values and the preference of the patient. The 4 principles of bioethics has been around for longer than many of the people on the call might be old. Autonomy, beneficence, non-maleficence, justice, and the one may be in conflict with the other. Now, in those cases, you have to consider which way is the heaviest, given that specific circumstances. And it helps to phone a friend, and it helps to phone a friend with grey hairs. We've worked hard for our grey hairs, and we might help you with a little bit of insight. But when you phone a friend and you discuss these cases, please make sure that you document these discussions as well. And all your transfusion-related decisions should be based on these 4 principles. Let's start with autonomy. Autonomy is the capacity of a rational, competent individual to make an informed, uncoerced decision. And we know that competent adults have the right to decide what will and what will not be done to their bodies. So what does this mean in transfusion? It's 2 sides of the coin. On the one side, it's informed consent, and on the other side, it's informed refusal. So as far as informed consent goes, the HPCSA booklets are very clear. The requirements are the patient must be competent to understand, and the patient must comprehend the disclosure. Also, the patient must receive full disclosure, and the information must enable the patient to make an informed decision. Then the patient obviously consents or refuses the proposed intervention or treatment, and all of this must be documented. Now, if you think about informed refusal, the most important thing is we have to respect the patient's values and beliefs. We don't have to agree with it, but we have to accept it. It must be fully documented, just like with any other consent discussion. But here's an important thing that I learned from all of you in the hospitals across the 8 provinces that I traveled through. Many of you have approached me after I gave this talk in person, and you would tell me, you know what we see, doctor, during the day when the family and the friends are in and out of the hospital and coming to visit and, sneaking a peek at the file, the patient says, no, I don't want a transfusion. Come night time when everybody is gone, the patient would call us back and say, can you do the transfusion before tomorrow morning, but my family must please not find out. And that made me fully understand what coercion means. We as healthcare workers can, through our preferences and our unspoken preference, actually coerce the patient into saying yes. But equally, the family and the social structures and the social pressure on the patient can coerce the patient into saying no to a transfusion. And if we truly want to make sure that our patient have got the opportunity to make an uncoerced decision, we must ensure confidentiality for our patients. Please remember that previously autonomous persons that are presently incompetent, we have to respect their previously expressed wishes. Moving on to beneficence, that's our duty to act with the benefit of the patient, promote patient welfare, but the one thing we tend to forget, and most definitely I did not think about when I was still in clinical medicine, is that beneficent actions can help to prevent harm and remove conditions that may cause harm. So let's talk about this in the transfusion setting. First of all, and this sentence will repeat several times this afternoon, transfusion must be based on a genuine clinical need. If any post-transfusion information becomes available of possible, potential, or probable harm, the patient must be informed. And this is where you will receive a letter from the Blood Services Lookback Department. We might send you a letter to say the patient might have been exposed to a window period donation, and you have got the legal and the ethical obligation to bring the patient back and test the patient for the marker we indicated. You cannot not respond or not act when you receive that letter. It would be deemed unethical. All information concerning a transfusion must remain confidential, and we mustn't forget the nosiness of family and friends coming to visit, and everybody has a smartphone and everybody takes a photo and everybody Googles. We have to ensure confidentiality. You cannot limit your patient's options just because your knowledge didn't keep up. You must know the basic patient blood management principles. It is truly an ethical requirement. Non-maleficents speak to we must do no unnecessary or unreasonable harm. We must not expose our patients to unnecessary risks, and we cannot deprive others from the goods of life, especially in a setting where we are often short of certain blood products. In transfusion, we're back to the fact that transfusions must be based on a genuine clinical need. Otherwise, we might be depriving others of the goods of life, and we are exposing our patients to unreasonable and unnecessary risks. You always have to weigh the benefits and the risks, and you have to choose the best course of action for that particular patient. You must avoid unnecessary transfusions. We all remember that. But what we forget is that the risk related to transfusion is not per transfusion episode. It's per every product that we transfuse. So therefore, we also need to avoid the transfusion of unnecessary products. If we have inadequate knowledge of the treatment, if we don't know patients on a chronic transfusion regime must get leukodepleted products, we are exposing the patient to unnecessary or unreasonable risks. If our standard of care is not adequate, are we still letting the blood sitting on at the nurse's station in a brown paper bag for who knows how long, but we walk past it because it's not my patient being transfused, but somewhere a patient must receive that product that has been out of the fridge and nobody is checking for how long. Are we still running the blood tubing through a bucket of hot water in theatre because we want to warm the blood and we convincing ourselves that that's the appropriate way to do it? All of that speaks to the standard of care. Very importantly, the use of uncross-matched emergency fridge blood. That is uncross-matched blood. It has not been matched to your patient. The risk that you expose your patient to is immense. Are we using that because we don't want to send the driver after hours to the nearest blood bank? Because we don't want to call out the courier for an additional trip after hours? It's not justifiable to expose the patient to that risk. If we have elective surgery cases and we don't want to postpone the surgery because everything is arranged and you waited so long for a spot on the theatre list, or you struggle to get the offs out of the medical aids and you don't want to postpone, but the patient is anemic, let me just quickly transfuse the patient the evening before the time. That is unethical because you are exposing your patient to a definite unnecessary and unreasonable risk. Please don't go there. The principle of justice speaks to the equitable distribution of benefits and burdens to individuals and social institutions, and the fair and equitable treatment of all patients. So in transfusion, we are looking at the fact that all patients should be treated equitably for the same condition. If a lady delivers in Lusikisiki or in Springbok, or whether that same lady delivers in Garden City in Joburg, she must have access to the same basic blood products that will ensure the optimal patient outcome. Medical decisions relating to transfusion should be based on the best available evidence and treatment, obviously adapted to your local circumstances. If you don't have a cell saver in Springbok, nobody can blame you for not using it. Although, in all honesty, if you still don't have tranexamic acid available, eyebrows might be raised. Patients should receive the most appropriate blood products that are available. If you have got a patient with a massive bleeding and you would prefer cryoprecipitate, but there is a shortage currently in the country, nobody can fault you to use if you use fresh frozen plasma. That is the most appropriate product that you have available, although your first choice would have been cryoprecipitate. A patient should only receive those products that are clinically appropriate and will afford optimal outcomes and safety. And please remember, in a country where this is a scarce resource, wastage on one end may impact on the greater patient population. Distributive justice speaks to the fair, equitable, and appropriate distribution of healthcare resources, the allocation of scarce resources, and the care of uninsured patients. And that is why SANBIS is fighting very hard to make sure that it does not matter in which hospital you are, where in the country, we are doing our utmost best to have the same set of products available for you everywhere. I love numbers. Numbers are beautiful, but numbers are also very dangerous if you don't have enough background knowledge to interpret them correctly. I would like to share one of my favorite publications. This looked at the red cell usage patterns in South Africa from 2014 to 2019. And I can tell you now, 2020 to 2023, the picture has not really changed. So it's basically the same picture. So what they looked at is on the left-hand side in the dark blue is the public sector. On the right-hand side in the light blue is the private sector. Now on the right-hand side of each of the graphs is the female population. Now if you look at the female population in the public sector, it kind of looks like the side view of a pregnant lady, né? And that is exactly where the red cells in South Africa is going. Women of childbearing age. However, if you look at the private sector, on the right-hand side, the female population, it's basically a flat line. You're not seeing the same pattern. So you need to stop and ask some questions. What is happening in the public sector to our female population of childbearing age that they need the majority of red cells in South Africa? Yes, the public sector is by far the biggest sector, but one would at least then expect a smaller little baby bump in the private sector if that was the only reason. No. You have to consider access to care, access to good antenatal care. Are there iron supplementation available everywhere? Are so many of our pregnant ladies just hovering on that verge of anemia that a normal delivery's volume of blood loss pushes them over the edge and the doctor have no option but then to support them with a transfusion? What is going on with our uninsured females in South Africa? From the same publication, you can see the per capita use in different sectors. Far right is the per capita use in the private sector, 34, 36, 37, 38. Second to right, per capita use in the public sector, 11, 12, 11, 11, 11. Does this mean that private doctors are wasting blood? Should we drag them outside and tar and feather them because they're wasting the scarce resource? The answer to that question is no, and I'm going to show it to you just now. This is not an indication of the private sector wasting blood. This is an indication of the access to care challenges in the public sector. In order to get a transfusion, you must get to see a doctor. If there's not enough doctors to see enough patients, those transfusions will not be requested. You have to have access to a level of care where the intervention predisposes you to a transfusion. If that level of care is not generally available, obviously the transfusions that happen will be less. Let's look at a bit of SANBA stats, and this is 8 provinces of South Africa. If you look at the average units per patient in the public sector, this is red cell products. It's 2.3 in the public and 4 in the private, almost double. If you look at the transfusion average HB triggers, it's 8.2 in the private sector and 7 in the public sector. Clearly the private sector is not wasting blood. But the level of care that our public sector patients have access to does not require as much transfusions, or they just cannot access us, or we are so worried about the blood bill that we probably don't check their HB before we discharge them. There's a myriad of reasons that you can go and interrogate if you see the same pattern in your hospitals happening. Let's look at plasma products. 3.6 in the public, for almost 6 in the private sector. If you don't have access to something as commonly used as a plasma exchange, for a plasma exchange we use anything from 11 to 17 units of plasma per exchange, in other words per day, for several consecutive days. If you have access to that type of care, obviously then your plasma usage will be higher. If you think about the platelet usage, the same pattern we see, 1.8 in the public and 3.4 in the private sector. The higher level of care you have readily access to, the higher your specialized blood product use will go. So let's talk about law, the little devil with the very sharp pitchfork. Chapter 2 speaks about informed consent, not just for transfusion, informed consent in general, and it's very specific that the user, the patient, must have full knowledge, and that the healthcare provider, we as the doctors who request this transfusion, must inform the patient. We need the consent of the patient after we've given them information. The patient must participate in the decisions, and yes, there are certain circumstances when we can deliver a service without consent. We'll get there in a couple of slides. Section 13 is of great concern to me, and that is our obligation to keep good quality clinical records. And you can actually go and read what is considered to be a good quality clinical record. And the reason why that is of concern to me is because of the fact that that little irritating blood request form that you all hate so much because you keep telling me it's too much writing, that's both a legal document and a clinical record in South Africa. And if I look at the quality of information supplied to SANBAs from 8 provinces on those documents, I am very concerned about whether or not we are truly meeting Section 13 of the National Health Act. Chapter 2 is very clear. Informed consent must be done by the treating doctor for a specified service in a language that the patient can understand at a level of their understanding. Remember, the HBCSA booklet from an ethical perspective says the patient must be able to comprehend what you tell them. So here, from a legal perspective, it's the language and the level of understanding. It must be written and documented, there must be a witness to consent, and if there's refusal of treatment, obviously the whole process must be followed. You must tell your patient what you're going to do, the benefits versus the risks, and here I'm a little worried always, because I do think doctors in South Africa still underestimate the risks of transfusions. They think of transfusion-transmitted infections and they think of incompatible blood. And here and there you will get somebody who thinks about, okay, maybe there can be an allergic reaction or a fever reaction, but overall the true risks of transfusions are very much underestimated by doctors in South Africa. You have to tell them about the available alternatives, the likelihood of success, the number of interventions planned, the recuperation time, and the costs. But when are you allowed to administer treatment without the patient's consent? I, as the patient, can mandate somebody to act on my behalf. You can ask the spouse or the partner, the parent, the grandparent, the adult child, the brother or the sister. Careful, because the order in the legal documents is very specific and you must stick to that order. However, in a very cultural, sometimes very hierarchical and patriarchal system that still exists, it might be considered disrespectful if you follow that order. Handle these discussions with care, but do not deviate from the legal order that is required. Treatment can be authorized in terms of law or by a court order, and if failure to treat poses a serious risk to public health, of course, you may intervene and go ahead with treatment. If delay in treatment might result in death or irreversible damage, and the user has not expressed, implied, or by conduct refused that service, then you may continue with treatment. However, if there's any indication that this person previously expressed a wish to not be transfused, please don't override that wish just because the patient is in a life-threatening situation. Chapter 8 in Regulation 179 speaks specifically to transfusion. Now, Chapter 8, Section 59 read, only a registered medical practitioner or dentist, which worries me, especially since I went for an emergency dental procedure yesterday, or a person acting under the supervision or instruction of the doctor may administer blood. Let's stop the sentence there. So in South Africa, we don't have the privilege of having so many doctors around that we can stand next to the bedside and supervise the administration of blood being administered. So the only thing we can do is to give a proper instruction on how to administer the blood product. And that instruction is a written prescription. Now, I was very privileged to be part of discussions with SANC way back in 2012 regarding this, and they were very clear that unless a blood transfusion is prescribed, formally prescribed, properly prescribed, the nursing staff are under no obligation to administer these products. So please prescribe your transfusions. The second part of the sentence read or prescribe blood or blood products. Now, clearly something went wrong because in March 2012, Regulation 179 was published in the Government Gazette, and it was very clear. No blood or blood product may be ordered unless it's prescribed by a medical practitioner, the dentist is out of the picture now, in writing on a form created by the Blood Transfusion Service. So that is the current legal requirement as it stands in South Africa. Regulation 179 also spoke about hemovigilance, and it was very clear that participation in the national surveillance programs is a legal requirement for all of us. Now, if you think back to what I told you on the ethics part of the talk, participation in the Look Back program is also an ethical requirement. So the surveillance programs is all adverse events and all lookbacks. So it's not optional. You must participate appropriately with those. So this is the hated form where all the doctors tell me, why do you need me to fill in all this information? And I hope I will be able to show you why. First of all, we want the patient information. Now, it's a legal requirement in South Africa that all blood must be traceable cradle to grave or vein to vein. So we must know what happened to the product. But there's also a safety factor in here. Mokoena, spelled M-O-K-O-E, and Mokoena, M-O-K-W-E, are two different patients on my Meditech system. So today, Mokoena K-O-E, the sample arrives with a request form. I type her and she's a B positive. And we issue B positive blood. Later tonight, Mokoena KWE comes in On Meditech, it's a different file. I open a new file, I type this patient, and she's an O. It could be, because they're the same patient in the ward in the background, and the spelling and the attention to detail was not there, that the reason why she needs blood so quickly is because she's hemolyzing, because she's actually an O and we issued B earlier, and there was a sample switch in the ward. Now, if you give me the correct patient information accurately every time, I will immediately spot this when I open her file and I cross-match the second sample. I can immediately phone the treating doctor and say, "Doctor, this happened. You might be looking at a patient hemolyzing. Please send us a third sample that we can see what the actual blood group is." If you don't give me the correct answer, poor patient Mokoena, irrespective of the spelling of her name, might actually have a severe intravascular hemolysis and kidney failure. Then, what product is required? Do you know that patients that is likely to receive multiple transfusions must receive leukodepleted products from the get-go? Do you know that patients that have an underlying condition that might in future benefit from a stem cell transplant must receive leukodepleted products from the get-go? Do you understand that all patients under the age of 1 must receive pediatric products? So this is where your knowledge come in. And this is where, if we have a history of the patient on Meditech, I can phone the young intern and say, "You know, yesterday the registrar ordered filtered red cells for this patient. Are you sure you want normal red cell patients tonight?" If you give me the right details. This is where you make your choice regarding pre-transfusion testing. And a very worrying trend that we're seeing in the private sector is that these poor nursing sisters, so the private hospitals very infrequently have blood banks on site. The majority of blood banks are in public hospitals. So the private sectors hospitals are dependent on a courier system to get their samples to the blood bank and to get their blood back from the blood bank. Now, after hours, these poor nursing sisters are under immense pressure when they phone the driver for an after-hours trip, because there's cost implications. And they're only allowed to do so for emergencies. And therefore, unless they tick emergency on the cross-match form, the driver is not going to go take their sample to the blood bank. But what this poor sister doesn't realize is that what she's indicating there is not the urgency of the trip, it's the type of cross-match that we're doing. And an emergency cross-match is a partial cross-match. We haven't screened for irregular antibodies that is active at 37 degrees yet. In other words, the temperature at which your patient is functioning, we haven't screened for the antibodies that's active at that temperature. What the poor doctor is blissfully unaware of when this form is being filled in on his behalf, that legally he remains liable for exposing the patient to the risks of transfusions. And because Regulation 179 says it must be completed by the medical doctor in writing, he won't have a foot to stand on if the patient suffers any consequences due to the fact that only a partial cross-match was performed. Hopefully that's some food for thought for you. This is where you give me the diagnosis, and a shocking amount of these forms just have the words chronic anemia, D64.9, which is anemia unspecified, and yet we're very happy to put that quality of information on a clinical record. Now, this is where the doctor who is requesting the blood gives me their information. And a big problem here is the contact number. Remember, if you make a decision to expose the patient to the risk of transfusion, you also have the obligation to be available, to be contactable, if there is any urgent discussion the blood bank needs to have with you. Also keep in mind that if we find anything abnormal, me as the doctor on call is not allowed to authorize release of those products until I've spoken to the doctor who requested this blood product. Meaning, if you give me a short dialing code for a public hospital where nobody answers the phone, If you give me a ward number in the private sector where the nursing staff refuse to give us the direct contact numbers of the private doctors, there's going to be a delay in treatment for this patient. And from a legal perspective, it will unfortunately be the doctor who requested that's liable. It won't be the blood service, because we were not able to contact you to discuss this abnormalities we found. Then this is my favorite question, and this is the bad part of doing this talk virtually. Because when I'm in the room, I ask the question, who of you have ordered blood in the past 2 months? Several hands will go up. Then I ask the second question, who of you have read this in the past 2 years? And a couple of hands will remain up. This is a legal document. It's a clinical record. And you sign directly underneath this pink block. This is what you sign your name to. You sign that you know blood may transmit infectious diseases. You sign that you know how blood is collected in South Africa, what we test for, how we test for it. You also sign that you acknowledge that in a country with a high disease prevalence, the blood transmitting disease is possible even if the unit tests negative because of the window period of these infections. Then it says in nice big fat red letters, the doctor who orders blood must take this into consideration, and that you have discussed the benefit and the risks with the patient and you got informed consent. You also say that this transfusion that you are requesting here is medically justifiable and that you have considered all alternatives to the transfusion. This is what you sign on a legal document on a clinical record. So this is the emergency fridge form. So we've got, like, Sanbus has 453 little emergency fridges stationed in hospitals who don't have blood banks on site, because there's only 84 blood banks and we are servicing just over 530 transfusing facilities. Now this is uncross-matched blood. It's emergency stock. In other words, you know it's O positive or O negative. You know from the ABO blood group, it's an O. You know it's D positive or D negative. Now, to put this into perspective, and I'm sorry for the hematologist on the call, because this is going to put you to sleep, but for the non-hematologists, let me just put it into perspective for you. In the rhesus system, there's D, there's little e, there's big E, there's little c, there's big C. But you only know it's D positive or D negative. So that's for the D group. For the ABO group, you know it's O. There are 35 blood group systems and there are over 300 red cell antigens identified. Yet, we know about 2 of the blood group systems. It's O, D positive or D negative. I hope you understand the severe risk that comes with uncross-matched blood. So, life-threatening situations only. Then, this blood must travel to your facility from the blood bank, because you're off-site. That's why you have an emergency fridge. How does the blood travel there? When it gets there, what is the procedure in your hospital? Who seals it into the fridge? Is it tied with a cable tie, or can anybody remove it and just pop it back if the resuscitation failed and tomorrow night you are unaware that the blood has been lying outside for 3 hours last night and you use it on the next patient? Is somebody taking the temperature when it arrives? Is somebody maintaining this fridge? Is somebody checking the temperatures of the fridge twice daily? All of those things comes with legal implications if you are the doctor who made the decision to expose the patient to the risk of this unit in the emergency fridge. Obviously, we send this blood out with a blank form because we don't know who the patient is who's going to need it, who's the next emergency coming through the door. So you need to send the form back to us so that we can fulfill the legal requirement of traceability. This is either an O neg or an O positive unit. Just yesterday in KZN, I had to expose, and it feels like me as if this happens on a weekly basis, because although the O stock in the country is 12 days. The O negative stock in the country is 2.7 days. Now, if the stock falls below 3 days, there are rural emergency fridges without O negative blood. That is the reality in South Africa. And yesterday again, I had to speak to a doctor and we had to expose the female, luckily not of childbearing age anymore. The previous call I was on, it was of childbearing age. We had to expose an RH negative lady to RH positive blood. You have to perform an RH test kit on this patient before you remove the unit from the fridge. You cannot just use O negatives for everybody. Your diagnosis. Does your diagnosis indicate a life-threatening situation? I have audited numerous of these forms, and the words chronic anemia is not uncommon on this emergency blood forms. Then this is where the doctor who made the decision to expose the patient to the risk of uncross-matched blood signs their name. Now, if you sign on behalf of another doctor, it means legally you are responsible for that decision. Litigation is a reality in South Africa. It tells you faulty blood transfusions are one of the reasons you can sue. It tells the patients out there that they have the right to look at their records. It also tells them when it's medical malpractice, if there was no informed consent taken, if you didn't explain the risk, if there was improper testing or an administrative error and the wrong blood type was being transfused, sample switches. The blood transfusion was given when it wasn't necessary, it's deemed medical malpractice. That's a scary thought. If the blood transfusion was administered improperly, and obviously if we didn't properly screen for infections. It also tells you who to sue. You can sue the doctor who performed or ordered the transfusion, the hospital where it took place, or the service who supplied the blood. The intellectual liability speaks to the fact that harm or damage was caused, and if a reasonable person would have foreseen harm and taken steps to avoid, but you as a defendant failed, and you will always be measured against a group of your peers. Now, if you follow accepted guidelines and you have solid policies and procedures in place, it will be very difficult to find you guilty. Criminal liability, one of two things: assault or culpable homicide. It's easy. You administer a transfusion without consent, you've assaulted the patient. If you've wrongfully or negligently caused the death of another person, you're guilty of culpable homicide. And just to inform you that there was 2 such cases in South Africa in the past, one a doctor and one a blood transfusion medical laboratory technician, and both had to do with incompatible blood being transfused, and these were 2 different cases, and both of them were found guilty of culpable homicide. So I've given you a lot of headaches and a lot of worries. I must give you some solutions, and I've tried to group it together for you. So first of all, you have to transfuse blood when it's medically indicated, and you have to warn patients of the risks and available alternatives and obtain and document informed consent. Colleagues, that's easy. We as the doctors are responsible for this. We are there when this happened. It's 100% in our control. The next group, slightly more difficult because we're not there anymore, but legally we're still responsible. You have to correctly identify the patient and the units, ensure appropriate compatibility tests have been performed, that the blood has been handled correctly prior to and during transfusion, it has not expired, and only responsible people are allowed to administer blood. How do you do this if you're not in the ward? It's very simple. Tomorrow morning you go and you ask, where is this hospital's transfusion policy? And you read it. But you read it from a different viewpoint now. Now you read it to see whether or not that policy adequately covers these points. Because if it does, it's very easy. When you prescribe the transfusion, you say, please, according to hospital policy or hospital procedure, which should include all of these checkpoints. The next one is to transfuse blood at a proper rate, easy as pie. If we write a prescription for the transfusion, it will be there. Last group, also a bit of a headache because we're not there, ne? You have to observe the patient before, during, and after the transfusion. You have to effectively manage the reaction. You can only manage a reaction if the staff gives you a call and say the patient is reacting. So the question is, does the policy adequately guide them on what a reaction looked like and when to phone you? You must retain blood samples as required, and you must report any reactions or death. So go and read your hospital policy with new eyes. And then lastly, you have to participate in the Look Back program. That's the legal responsibilities of anybody who orders and transfuses blood in South Africa. If you can tick all those boxes, I promise you, you will have the best possible patient outcomes and you will sleep soundly at night. So please empower your patient and allow them to participate in the discussions. Always consider the ethical principles. They're old as the mountains, but they still hold solid. And don't limit your patient's options because your knowledge is outdated. Know your legal obligations and your responsibilities from a legal perspective. Always apply PBM measures and always screen for and treat anemia. Thank you very much for listening. I can stop that and then I'll put on my video that we can answer a couple of questions.
Petro-Lize, thank you so much. Again, what a comprehensive and multifaceted look at this issue. And I cannot deny that one often gets a little bit of a turn in the stomach, noticing that you probably made some serious mistakes in the past. Not talking about you, talking about me.
Oh, I definitely made them. Trust me, Vernon. I thought I was a safe doctor until I joined Sanbus.
We're very grateful, and I think the key message is that this talk, we just need to keep on giving, and we need to make sure that the message gets to the junior doctors, who I don't think are often properly trained in this in their undergraduate studies. I want to start with a comment from Dr. Yaglin Naidu. For those who don't know, Dr. Naidu is a clinical hematologist in KwaZulu-Natal. He works in Pietermaritzburg and Gray's Hospital, and he's also received the prize from the Provincial Minister of Health for his excellent work in patient blood management and blood conservation. And Yaglin says, "Thank you for the excellent talk. I always learn something new with respect to transfusion medicine. Gray's Hospital in Pietermaritzburg restricts blood transfusion ordering to the medical officers and above." It's very good. It's very good. Until you've trained your interns, I think this is really a good safeguard. This policy ensures accountability, that consent is taken and correct blood product is used based on our accountability guidelines. And they're busy with a master's research project to audit this practice. Yeah, Yaglin, I love that. Would also like to invite you actually to come and present that to us when it's ready. And please let me know when the data comes out so that we can present it here, because I think this might be a practical way in which other people can do something similar, and also see what challenges you found. I'm sure many people will immediately say, "Ooh, what about after hours and when the intern is on the floor and the MO is not there?" Maybe you can throw something in the chat there on that. Petro-Lize, I want to quickly ask you about this look back story. And I think this is such an important thing that you mentioned there as well. I've often encountered that doctors are called by the blood service about a patient who may have potentially contracted or received blood from a patient or from a donor that was later found to have some infection. And then the doctor says, "It's not my problem." But I just want to, again, support you in that and say, listen, it's all of our problem. Everybody that is part of the chain of care has the responsibility. And the one who prescribes, when you put your signature on that form, you actually also confirms that you are willing to be part of the Look Back program. If you're not, you shouldn't sign that form. You should give it to somebody else. Am I right?
Definitely. Vernon, what I have found when speaking to doctors who is negative or I don't want to use the word obstructive, but that says, listen, this is not my problem, it's your problem at the blood service. The words they often use is, what am I supposed to tell my patient? And then it made me realize that that is the instances where proper informed consent discussions didn't take place. Because if you adequately had that discussion with your patient and you told them about the fact that, listen, SANBIS use state-of-the-art testing, but there's still a window period. It can still slip through. This discussion would be far less difficult with the patient once you receive that letter or that phone call from SANBIS. So on the one hand, it comes back to lack of informed consent discussions. And on the other hand, we don't have a choice. We've got the ethical obligation and the legal obligation. We must participate in this. Thank you. It's a very important fact that you've raised.
No, thank you. It's just something that I've really seen play out in practice. And then I'm phoned as the head of the unit or the department to say somebody in your department is not willing to help us. And that creates a whole chain of unnecessary conversations and admin, you know. So I'm very happy that you mentioned that. Thank you, Petro-Lize. I don't see any other specific questions in the chat, except for a number of thumbs ups. I'm sure everybody really appreciated this. I think some may go home shocked, others may go home fine-tuning their practice. But I want to remind you all that the recordings of these sessions are available on the Gastro Foundation website. So this might just be a great talk to either invite Petro-Lize to live or to go to the website and play at your journal club or your academic meetings. And that is one step everybody in the room can take to play your part in patient blood management and in blood safety, is to share the knowledge you've received today with someone else. So really, not to try and be paternalistic, but I really want to encourage you all to just share this, maybe schedule it on your academic program or send it to the person who creates that schedule and ask them, can we look at this? I think this is such a great opportunity, because we all say, and we all agree that students and interns are not properly taught. Maybe this is something to say, before you can be an intern in this department, day one, you must watch this video. Sit down here, look at the video, and you prepare 5 questions for them to make sure they actually watch the whole thing. So from my side, a big thank you, Petro-Lize. Very, very useful as always. We want to say thank you to the ECHO team at the University of New Mexico, the ECHO India team, the Gastro Foundation, to Cheryl and Karen, who's always there to help us organize these sessions. Thanks to the sponsors, for the gastroenterologists in the room or anybody else that's interested. The topic for next week will be lower endoscopy. And for the patient blood management people, you may be aware that the World Health Organization implementation guidelines were published in April, about which we're very excited. And the speaker of the next one will be Prof. Axel Hoffman, who was the main driver behind that, and he will be sharing the information with us. Also want to let you know, for the first time, the South African Clinical Hematology Society annual conference, the HemOnc, which happens in September, will have a specific patient blood management session. So things are happening. PBM is alive and well, and I want to thank all of you for being such wonderful supporters and regular attendees of the PBM ECHO meetings. With that, we're well in time. I say goodbye to everyone, and thank you, Petro-Lize, once again. Bye-bye.